I'm being recorded. I'm Hazel Nichols. I'm a cancer epidemiologist at the University of North Carolina in Chapel Hill. And the COVID-19 pandemic did me a big favor because now people are familiar with the term epidemiology. And I can't really tell you much about infectious disease, but I can tell you about cancer in populations and health outcomes in populations of individuals with cancer, cancer survivors. So I often use large population data sets, and these are some of the states that my work has been in, and I'm going to tell you more about that. So for this talk, what we're really focusing on is in populations, who accesses fertility preservation after cancer? Are they characteristics of the individuals? Does it depend on your age or your family structure or your racial and ethnic background? Or does it depend on more contextual factors under this umbrella of the social determinants of health shown on the right? So things like, what kind of community do you live in? What are the resources in your neighborhood? How far do you have to travel for your care? So these are the types of characteristics that we look at in relation to figuring out who can access fertility preservation. And in order to do that, we identify data sources that we can use to inform this question. So I use data from cancer registries, often statewide cancer registries quite a bit. Vital records give us information about deaths that occur or new births that occur. And then recently I've been collaborating with the Society for Assisted Reproductive Technology to look at their clinic outcomes from fertility clinics. We also link with data from administrative insurance claims or healthcare systems. And then we get information about neighborhoods from the census or other geographic data. And we work with the data providers of each of these sources to get the appropriate permissions to bring data together. We find ways to do that ultimately protect the privacy of individual patients so that the research team is not looking at someone's name and address directly, but we're pulling this information together. We're taking out that identifiable information and we're looking at what's left to try to understand patterns in populations. So this is work that was led by Claire Miernick, who is now at the Cooper Institute. And she looked in California at disparities in fertility service access after breast cancer. And these are some of her findings. So one thing she reported is that women who are at the older end of it in this reproductive window, at the older end of a breast cancer, at an older age when they're diagnosed with breast cancer, are far less likely to use fertility services, 83% less likely. Married women, 36% less likely than unmarried women. And women with children, 61% less likely than women without children. Now, if this actually reflects patterns of desiring future children, that's absolutely fine. But I think what we're concerned about in the disparity context is this also reflects sort of an unconscious bias towards assumptions of who wants these services. So we see from other data that often women who have children desired more children, but there was an assumption perhaps that this was not a critical concern for them because they already had children. Similarly, older women, there may not be as great a recognition of women wanting to start their families at older ages. We also look at characteristics of the environment and the demographics of a group. So Black and Hispanic women are less likely to access these services than white women. Privately insured women, as we've talked about today in California, where what services are covered for which groups. Privately insured women are 3 times more likely to access fertility services, and women in high SES neighborhoods are more likely. This is a map of North Carolina, and I don't have the corresponding map for California, but I have a feeling it's not completely dissimilar. This is work that was led by Nidia Rodriguez-Ormaza, who's now at Stanford. And what you're seeing here, those boxes in North Carolina, those are places where you could have fertility preservation enacted. Those are clinics you could go to. So you can see there aren't that many of them, and they're not distributed everywhere across the state. The lines are young patients who are diagnosed with cancer, who are receiving, therapies that may affect their fertility. The blue lines are ones, that's the distance you would have to travel to get to your closest clinic. The red lines mean your closest clinic is actually out of state. And what you can, I think, just eyeball from this map is that the closer you live to a clinic, the more likely or the easier it's going to be to access these services. Okay, so recommendations. I grew up in a sort of rural environment, and now I have this interesting personal professional intersection where we always talk about silos and how we're all siloed. And I have a very strong mental picture of these big grain silos standing alone. And I'm always surprised that other people actually know what silos are. So I do think that siloing is a problem. So there are new advances that have been adopted, things like telehealth that are going to help us bring more services to more patients. But I think we also have to keep in mind that there are multiple priorities going on at the same time. So people need to get the information about their fertility and their options. They also need to get the information about how to manage their diabetes. They also need to get information about how to access mental health services. They also need to get information about, exercise modalities that might help them tolerate their treatment, whether when they'd had their last dental care, if they're going to have treatments that, are going to give them dry mouth, things like that. So we have to fit this piece in the giant overwhelming package that is coming. We also have to keep in mind that the cost of fertility preservation is occurring within the costs of cancer care and the indirect costs of having a cancer diagnosis at a young age. So I think it's not just one thing. We have to make this work for patients' whole lives. And finally, I think that navigation is going to be essential. And again, to the extent that we can give people trusted resources or available opportunities to talk through things, not necessarily one by one, but things that they can get a bigger full picture of the services that are available to them. I think that will help reduce burden on patients. And that's all I've got. So thank you very much.
We are largely on time.